Good afternoon. I'm here again. So Dhanush asked me, sir, you have to talk something basic. So I have a principles and philosophy of head neck, which is the welcome talk for our residents. So I thought I'll just choose a part of it and talk about it. So in case you're wondering what I'm talking about here, it's basically how to make your decisions on what to do and how exactly to do. Uh, Head neck reconstructions are evolved over time from pedicle flaps to free flap to this era where we have multiple options of perforator-based flaps, even in pedicle version. And also our endpoints have changed from basic form and wound healing to have predictability, better cosmesis, and as we look ahead, maybe dynamism, secretion, sensations, and all. But what exactly is the grand strategy of technique when it comes to head neck reconstruction? So I think the first thing which we need to realize is it's not a battle between a free flap, between a regional or distant flap, and a local flap. All of them supplement and complement each other. And often the surgeon's bias is an impediment in making the right choice. So every defect has an AHA solution which will just fit. It's often your bias towards a free flap or a pedicle or a local flap which will be an impediment. Now, in making these choices, often the human factor often plays a big role. You have to titrate it to your skill, to your setup, to your assistants, probably the mood of the day. Now, whatever happens, always remember there's a patient attached to the defect of flap you are doing. We become one of the blind men of Hindustan where we look only at the defect and flap, but you have to take into considerations age, comorbidities, hypercoagulable states before you make a decision. Now, once all these things are taken care of, then you come to the technicality. So what I say, it's all reconstruction, not only head neck, is an attempt to achieve synergy, congruity, match between your compulsions, choices, and creativity, which is essentially the defect, donor, and the design. This is the grand strategy. So now let's look at each element in separation. So what do you do? Whenever you see a defect, try, assess, and understand it. Give 5 minutes to just assessing the defect. First thing you ask yourself is, what's the histology of the biopsy? A squamous cell carcinoma and an adenoid cystic carcinoma will have different survivals. You can play the long game when radiation is not involved in, the survival will be very good. Always pay attention to the nodal status in head neck reconstruction. A bilateral noded lymph node neck, a patient might not do very well in the long run. You might want the shortest part to a effective wound healing. So your choices might sway towards a simple PMMC. Once taken care of, even before the defect is made, always have a conversation with your resecting surgeon. Now, these specimens are not from internet, they're from Tata only, where the plan is a ALT and the head neck surgeon thinks it's an ALT, so you do a posterior segmental mandibulectomy to start with. But actually, when you'll have a conversation, you realize that both is presuming the other. We are presuming that it's a posterior segmental mandibulectomy, he's presuming you are doing a soft tissue flap for whatever reason. So you tell them, you excise exactly only what is oncologically indicated and take it from there. Honestly, almost every scapular flap I have done is resulted from this conversation. When you have the defect in your hand, look at the specimen and look at the defect. Analyze it, simple scale, measure it in 3 dimensions, X, Y, Z. This is often where things go wrong. You either disregard it, underestimate it, or inadequately address it due to whatever technical limitations. By what I mean, you need a thicker flap and you're not comfortable with an ALT, you do a radial. Now, this is a patient, our own patient, where there was loss of this synchrony. We have done a radial for a buccal mucosa defect, where there was marginal and little bot defect going posteriorly and soft tissue defect. And he has a cosmetic deformity. The raison d'etre of plastic surgery is cosmesis. He was a candidate for ALT. For whatever reason, technicality, it happened. But this is what we need to avoid. Now, when you have the specimen for the defect, break it down into components. What is the mucosal element which needs replacement? How much skin you need to replace and what way? What is the soft tissue elements? And also break it down to the special tissues which you can replace like bone and which you don't have a real substitute like tongue, lip or palate where you just need a secondary substitute to just fill it. Now, if there is a tongue or if there is a lip defect, always address the lip defect separately as compared to your primary defect. Close it if it's small, 1/3 to 2/3 share it. More than that, replace it. That too more in less in horizontal dimension, one more in vertical dimension. Now, what this does is, when you have break it down into the lift elements, you know what you are trying to achieve. Now, I just listed these functions each of these elements do. It's very surprising, but still most of our reconstruction, as I was talking with Ayyar sir just now, is filling the defects. We still don't have any answers to secretion. Very little we pay attention to animation. Dental rehabilitation is catching up, but as we said with radiation, it's not there. Taste, you're not even talking about it. Sphincter and stretch, we can do something about. So once you have got a measure of the defect, if you will just jump onto a flap without thinking, giving a thought to donor site, it's like playing half-court tennis. The donor site, you need to assess in its individuality. By what I mean is, you need to touch and feel it. Eyeballing is never enough. Now, every flap will have an ideal donor site. Now, for the flap one you're looking at, you have to think what is the surface area you need. You need thickness, you need a color, and you need a robust vascular basis with good length and lumen. Don't jump to the idea of a flap. I'll come to it why. And the donor site should be preferably closed primarily. Now, we have worked with the three workhorses. I think Madam has really set this philosophy very well. Radial, ALT, and fibula. Each of them have their specific attributes. I won't go into it. But what we need to appreciate is, morphologically, there is a lot of variation. ALT in a patient with a BMI of 19 is not same as an ALT in a patient with BMI of 30. Same thing holds true for a radial artery forearm also. And even within a same BMI, a male patient might have a much thinner thigh with a Cushingoid body habitus, and a female might have a much thicker thigh and a very thin radial artery forearm flap. So my point is, don't go by the names first. Choose flaps based on your morphology and back it up with a vascular basis. So like in an ALT, the proximal and distal flaps have different thicknesses. So depending on your perforator, you'll have a different flap. The medial and lateral thicknesses are also separate. If you look closely, even in fibula, your proximal and distal parts, anterior and posterior, have different thicknesses. And these become relevant when they go to the head neck and you are contouring it. Sometimes it will happen where your best thickest part of the flap is not where you want it to be. And you have a little bulk anterior towards the lip, and posteriorly where you need the thick part, it's deficient. So what you can do about it is what I'll talk in design. Now, every donor site has a morbidity, whether it's a flap or a skin graft. Look for these hypertrophic tendencies. Most common long-term complaint in our patients is itching and hypertrophy at the skin graft donor sites. Try to close your donor sites primarily if possible, as much as possible. Now, when you're assessing the donor sites, there'll be a set of patients who will have unfavorable donor sites. By that I mean you will have vascular anomalies. Allen's test might be unfavorable. You might pick up a peronia magna, or they might be major chemotherapy infusion and needle pricks on the hands, so radial is out, or there might be some trauma. Occasionally you will have really disproportionate or disparate to the defect donor sites. You might have a very thin radial or a very thick thigh. We have even put beautiful contoured ALTs which are yellow in color on a patient who's almost black. So if you can preempt it, it works well. And even excessive hair growth. Doing a submental flap in a small defect which will not be radiated, the patient is going to be troubled forever, a male hairy guy, by the hair growth. So once you have made these assessments, if you limit yourself to these 3 flaps and 2 pedicle flaps, it places restrictions on you. So what you need to do is to embrace the perforator concept and have a larger armamentarium of flaps in your scenario. Let's just see an example. Forehead flap historically was done a lot. Brilliant substitute for anything facial, especially if you need buccal mucosa and skin bath. But the donor site is just not good. So we use this basically scalp flap, which is the scalp skin for for complications or any sometimes more morbidities, more you want to reduce your free flaps. So this is a scalp flap. This is in post radiation. Now this was a very interesting case. This Raghuveer here, he had operated him. So this was a patient in whom a forehead flap was already done, and the buccal mucosa defect was extensive from one angle to another angle, and the whole ALT was wasted inside. And we did a scalp in him after a forehead. So why I always think this patient is special is these photos are not pre-op, these are post-op, where you can actually not see the scalp graft donor site. So the point is, if you need only an external replacement, doing a scalp flap and then replacing the remnant will actually give you a good morbidity compared to a forehead. This is for a complication, but you can play on the same donor site, similar vascular basis, and get a different result. So another girl, I think this was Madam Stein. She was a singer, palatal defect, little large. Now after Sandeep Mehta said maybe we should have tried a temporalis muscle, but we did a radial in her. Very good result, excellent. Every time she came follow up, she showed us this hand. Can you do something about it? So the thing is, if you have a conversation with patient about the donor site, or if you have a larger armamentarium for a similar morphology of tissue, you can offer the patient a choice of donor site. It will be amazing for your practice. So in this lady, we did a MSAP flap and she did well. Other thing is we talk of, as I talk of a larger armamentarium of donor sites, fibula, when you need to harvest really large paddles, especially in low BMI or nutritionally deficient patients, or when you do large numbers, the vascularity starts playing games with you. And these are all our patients. You tend to see these things. So occasionally, if you add another flap-like scapula in your armamentarium, it adds to it. Like this patient in whom have the segmental mandibulectomy with buccal mucosa and skin, we have done a scapula. And this is an exceptional outcome, I would say, in terms of everything. I've shown this. So the thing is, you have assessed the donor site, you have made a choice. But it's not just making a choice is not sufficient. It will get you there, but you're not yet there. So it's what you do with the horse which will matter. It could be a workhorse, show pony, equestrian, racing horse. So what you do with the flap is where the design comes in. So design is something which you have to think before you choose your flap. You have to imagine, plan, and wish for it. That's where things start falling. The first element of design is the incision planning, native skin incision, when the resection is taking place. So these are two of our patients where we did well-functioning fibula and a Tdap flaps, but there was native skin necrosis. Always have a morning conversation with your head neck surgeon. Balance your priorities between vascularity and excess about what it's scared. So there's a whole lot of things to it. What incisions you can avoid, how much to take. Avoid midline splits, avoid angle splits. Often it is possible to place in your flap and insert wherever you can. You have to balance it against radiated skins also. Okay. Bring in the principles of local flap wherever possible. If you have a buccal mucosa defect with a small skin defect, closing that skin defect with a local rotation flap will give you a better outcome than any free flap you can get from anywhere. But the buccal mucosa and volume should be corrected with the second free flap or whatever. So when you look at design in any flap, there are three elements to be balanced out. First is the suture line, which will be your insert. Second is the skin paddle, which will be your surface area or the shape of flap. And third is the volume. Often the problem happens with volume. Easiest way to achieve good volume is to choose the right thickness flap. Now this is nothing but planning in reverse really. Now to have more options in volume and flaps, you need to embrace the perforator commandments. You need to realize if you become comfortable with perforator dissection, you believe in the perforator concept, it opens up so many donor sites for you and almost everything goes perforator base. Now why perforator base? So what happens is almost every flap gives you a good fasciocutaneous option. It's assured vascularity. The perforator is small, so the flap can be. You can thin it. There is increased pliability, pedicle lengths increase, and donor sites often close. There's less seroma morbidity. It also gives you that you can control the third dimension. Any musculocutaneous pedicle regional flap, you'll never be able to control the third dimension. By that I mean you can thin the flaps, you can deepithelize and bury them, or sometimes when both work, you have to add another flap. So thinning is a very strong concept now. It's very well established across all perforator flaps. The next element of design is if you have a circular 5x5 lesion by a 4 centimeter, there's nothing much. Is when you have complexity. Like you have a hemiglossectomy with palate, with mandible. How do you balance all these out? I think the first question you ask yourself is, do you need to replace all elements? Is bone replacement needed or wise? Is tongue replacement needed or not needed? Moment you get an answer to this, you can move on to the next thing. That Is your one donor site adequate? If it's not adequate, just jump to a double free flap. If it's adequate, do you need chimerism and the liberty? Head neck reconstruction, you have to embrace chimerism at some point, because in these complex defects, often a single island will have to undergo too much stress to achieve, there is too deepithelialization, two suture lines, turning, it just doesn't work. So once you get chimerism in your play, for the same amount of tissue, you can have a larger suture line, more liberty to rotate, fill, deepithelize than a single thing. So essentially what I'm saying is you need to embrace multiplicity of islands, perforators, flaps, donor sites. Now, once these defect design is taken care of, there are three more things which you need to understand. Dentition, mouth opening, buccal mucosa. There's no point in putting a fibula with the aim of osseointegration in a patient who doesn't have teeth on the other side or the upper jaw, or who has a very poor mouth opening. So always this has to be a tick mark before you make any decision. And also remove all poor teeth because they have to be removed before radiation. Now, what radiation does is it affects design, defect, and donor site, all three things, and it sets a clock on our thing. Everything needs to heal between 4 to 6 weeks, maximum 8. Now, these are two patients where one appeared bulky before surgery and settled, the other appeared brilliant before radiation and led to a deformity later. So, radiation affects everything. So, this was one gentleman with the ALT flap, seemed bulky, but with radiation, it just settled fine. And sometimes you need to operate after radiation also. This opens up a whole lot of different problems. And sometimes you don't need to go there. For a small exposed implant, it's a battle you're unlikely to win. When you go into right for OR and put in a fibula, difficult anastomosis, blood loss, and end up with exactly the same amount of exposure. So we have our limitations. We still don't have an appropriate substitute for tongue, lip, and lid. Treat them with respect. Embrace obturators and prosthesis where failure has happened. And sometimes it just helps to use camouflage. Madam will remember this patient. We did a secondary maxillary reconstruction. Everything we did, he was not satisfied. Then someone came up with the idea, just do a small scalp flap and give him a mustache. It led from a conversation where all he wanted was a mustache because it's a thing of pride in his community. And after that, he disappeared. I'll just show three cases. So this is one gentleman in whom post-PMMC there was a nasocutaneous fistula troubling him and he had a bulk in the neck. So what we did here is the defect was there. The donor we chose as the previous PMMC and time generated a vascular basis. We divided the distal end. You can do this with delay also and used it to seal the fistula also and to improve his contour also. And the rest of the neck skin we used like a rotation flap. So this was a local flap at work. So this was a gentleman in whom had a severe contour deformity. One ALT was lost primarily, but you have to sometimes do heroic things. So as I said, it's not about pedicle or free. Sometimes there is no other option. So we underwent and did another ALT with end-to-side anastomosis to carotid and IJV, and he did pretty well after that. Sometimes you need both, like in this lady, just last slide. Like in this lady who had a previous rotation flap and a big 5 p.m. 5-liter blood loss after a big neurosurgery tumor excision. So what we did first is we used the previous rotation flap, derotated it and used it to cover part of the defect. And then she had very thin thighs and she was in the lateral position. So we harvested a scapular, parascapular, fasciocutaneous conjoint flap with primary closure of the donor site and used it to cover the scalp and anastomosis to superficial temporal. So a local and a complex pre-flap both coming together. This was she at 1 year post-radiation. And it's cases like these which bring out the beauty of our branch with plastic surgery. Thank you.